Welcome everyone to our second QA Forum of 2023. I'm Dr. Michael Novick, the Director of Education and Associate Director of Quality Assurance for vRad. Today we'll be reviewing some cardiothoracic cases. Before we begin, a bit of bookkeeping. This is our accreditation statement. And here are the learning objectives for this forum. Our first case is a 75-year-old woman with right upper quadrant pain. We'll begin with this PA radiograph of the chest. And have a scroll through these axial images from a CT scan of the chest with the lung windows on. Returning to our plain radiograph to review the findings. There is a faint pleural-based opacity in the left upper lobe, which is clearly visible on the CT scan where there is some associated wispy spiculation. A bit more inferiorly with the soft tissue windows on, we can see an enlarged lymph node in the aorticopulmonary window. More inferiorly still in the upper abdomen, there are multiple ill-defined heterogeneous hepatic masses. So this patient unfortunately has metastatic lung cancer which presented with right upper quadrant pain due to liver metastases. In this case, we were first presented with a PA radiograph of the chest, and the finding on that image was in the left upper lobe. Had we focused only on that finding when reviewing the CT scan, we might have missed the metastases in the right upper quadrant. Our next patient is a 58-year-old woman, status post-transient ischemic attack. Let's begin by reviewing these axial images from a CT angiogram of the neck. Here is a single slice from those images at the level of the upper chest, which demonstrates a filling defect in a branch of the right upper lobe pulmonary artery, which is consistent with a pulmonary embolism. Note also that there are small bilateral pleural effusions, and remember that when we're reviewing CT scans of the cervical spine or CT angiograms of the neck, we should always review the upper chest in the lung windows and the soft tissue windows, otherwise important findings could be missed. Moving on to our next patient, a 64-year-old woman with a history of metastatic ovarian cancer. These are axial images from a contrast-enhanced CT scan of the abdomen and pelvis. Many of the findings you would anticipate given the clinical history are clearly evident: pleural effusions, ascites, carcinomatosis, irregular pelvic masses, anasarca. Those of you familiar with my lectures will probably know what's coming. Note the small filling defect in a branch of the right lower lobe pulmonary artery, which is consistent with a small pulmonary embolism. Most of us who have missed these have missed them exactly one time. As soon as you add the lung bases with the soft tissue windows onto your search pattern, you will never miss these again. Next up is an 86-year-old woman with a history of tuberculosis presenting with hemoptysis. Let's have a look at the axial images from a CT angiogram of the chest. And the coronal images from the same study. Let's review our findings. Here is a single coronal image from the scan. There is some pleural-based consolidation in the left upper lobe with associated cavitation, volume loss, and bronchiectatic change. And just medially, there is a tangle of vessels, some of which demonstrate the same phase of contrast enhancement as the pulmonary arteries. Here is a different coronal slice, which again demonstrates the left upper lobe consolidation with some cavitation and bronchiectatic change. Here we have a nice view of the feeding artery, which originates from the pulmonary arterial system, and the draining vein, which empties into a branch of the pulmonary venous system. So this, of course, is a pulmonary arteriovenous malformation. Let's briefly discuss pulmonary arteriovenous malformations. The abnormal connection between the pulmonary arteries and pulmonary veins results in a right-to-left shunt. The vast majority of cases are asymptomatic. When symptoms do occur, they generally present in adulthood, even in the case of congenital lesions. The most common presenting symptom is dyspnea, although paradoxical emboli can also occur. Pulmonary AVMs are rare but occur more frequently in women. Congenital lesions can be associated with hereditary hemorrhagic telangiectasia. But there are also a number of non-congenital associations, including surgery, trauma, hepatic cirrhosis, and infections like tuberculosis. Lesions can be described as simple, which is the most common, and includes lesions with a single segmental feeding artery. Complex, which includes lesions with multiple segmental feeding arteries. And finally, diffuse, which is a rare designation reserved for patients with hundreds of pulmonary AVMs. If you are interested in further reading, this article gives an excellent overview of pulmonary arteriovenous malformations. Our next case is a 45-year-old woman, status post-trauma. These are axial images from a contrast-enhanced CT scan of the chest. Here are the coronal images from the same study. Reviewing our findings. There is an engorged, somewhat tortuous feeding vessel at the level of the aortic root. A different slice from the same study demonstrates the left anterior descending coronary artery, which appears to originate from the feeding artery. Yet another slice from the same study demonstrates drainage into the right atrium. This constellation of findings is consistent with a coronary arteriovenous fistula. Coronary AV fistulae are exceedingly rare connections between the coronary arteries and other adjacent cardiac or vascular structures, most notably and most commonly the coronary venous system. Large coronary AVFs are sometimes referred to as core medusae due to the serpentine nature of the vessels. Most lesions are congenital, and as mentioned, they are exceedingly rare. And the abnormal connection can be between the coronary arteries and essentially any adjacent vascular structure, including the right ventricle and atrium, the pulmonary artery, the coronary sinus, and the superior vena cava. Because coronary AVFs most commonly drain into the right cardiac circulation, they represent a left to right shunt and present with chest pain and dyspnea on exertion. In some cases, a continuous murmur can be appreciated during both systole and diastole. Help yourselves to this radiographics article if you're interested in some further reading on the subject. Our final patient today is a 28-year-old man with chest pain. These are axial images from a CT angiogram of the chest. Reviewing our findings. The heart is enlarged and there are small pleural effusions. At least one pulmonary arterial filling defect can be seen in the right lower lobe. And there is wedge-shaped pleural-based consolidation in the left lower lobe, suggestive of pulmonary infarction. Of course, the satisfaction of Search Devil sitting on my shoulder might tell me it's time for a well-deserved cup of coffee, but this slice a bit more lower down tells us otherwise. There is a lobular filling defect in the right ventricle. And this is, of course, consistent with right ventricular thrombus. So remember to always stick to your search pattern. Don't give up when you make some interesting findings, and stay with your routines. They will serve you well. Thank you very much for joining me again. See you next time for part 3.